honor to present a topic which is focused on the progress towards elimination of hepatitis C in Georgia and overcoming challenges through decentralization of services. So you can see that in some terms like the HCV services decentralized throughout Georgia, so I wish we could have such a network for HIV-like service as well. So as you see, there are 40 treatment centers all over Georgia. So there are 32 specialty clinics and 8 primary care services. The treatment protocols which we are using are progressing through the years. So we have started from the sofosbuvir containing regimens with interferon or without interferon, ribavirin, minus ribavirin. And since March 2016, we switched to the letinibasvir sofosbuvir harmonic-like regime, and it was used for all genotypes. And especially there was a lot of concern regarding the special type of the virus, which is very prevalent in Georgia. It's a mutated version of the genotype 2, but it seems that these regimes which we are using in Georgia are very efficient for all genotypes, including this mutant form as well. And since December of 2018, we have a possibility to have the patasphere sofosbuvir combination, and especially this is important for those who failed to be show sustained viral response, so the first or the second treatment course. Here you see the care cascade, which is really impressive, I think. So we are having overall cure rate currently over 98%. And as you see, there is a very high level of the testing of the population in Georgia, and confirmatory testing, and then inclusion into the program. But of course, we are looking forward to have more efficient inclusion of the patient within the program. So here you see the dynamics of the patients initiating the treatment. It's in green, and the overall data for the patients who are included in the treatment course in the red line. So as you see, there were 2 waves of inclusion of the patients. So there was an initial wave, and there was a really big wave in 2016. So the first one was initiation of the program, and it was dedicated for those who had advanced fibrosis level. And in 2016, it was expanded to all HCV infected patients. So we had a small elevation of patients inclusion when the velpatasvir actually started the new regime with velpatasvir. But as you see, the starting of the treatment is declining. So there is a really challenge for the program, because we need much more efficient inclusion of the patient to reach and to achieve the elimination for at least the large part of the elimination program to be fulfilled for the 2020. So one of the approaches is the decentralization, and in this regard, the persons who are using intravenous drug users are the main target, and PWIDs are the major source of the burden of the HCV infection in the country. And it is documented by several studies, including a large survey study back in 2015. But for policymakers, it was not really at first sight. It was not so. So it was not included the persons who were using drugs we are blocked from getting the service, and it is very ridiculous, of course, and under big pressure from the different non-governmental organizations and the clinics. Finally, it was like solve this problem, and of course the PWIDs should be the primary target for the application of the HCV treatment service and the elimination program. The recent modeling, like the mathematical modeling, indicates that priority treatment of PWIDs is needed to reach the elimination goals. So how it was the timeline of this process? In April 2016, there was a first meeting on this topic, and it was during the EASL conference in Barcelona. And in June 2016, there was a meeting of ECHO, is a international network led by the University of New Mexico, the telemedicine, and CDC, and we were the host of this meeting, and we have developed some recommendations, and it was approved by the technical advisory group, and there was a recommendation for TAG for moving towards this direction. In December 2017, there was a first meeting on HCV treatment decentralization, and finally the program of moving towards this direction was approved at the National Hepatitis C Elimination Workshop in March 2018. So as a result, two groups were formed, and it's under the Ministry of Health Decentralization Working Group. One is on harm reduction direction, and another in primary health care direction. So the first concerns and the general concerns which are related to integrating HCV treatment with harm reduction services was unwillingness of HR centers for personnel for incorporating this program, low trust among patients and preference to be treated at specialized clinics, and quality of treatment and poorer outcome. But all these concerns were not supported by any research for now, and so there were different projects in this direction. So I'll describe some of them. One is a study of to evaluate barriers of integrated care. It was funded by CDC and TEPINET. It was a CAP survey of OST and SP personnel on HCV care integration. And there is a qualitative evaluation of the treatment integration, patient satisfaction survey, and chart review from patients enrolled in the integrated care services. So as you see, the patient satisfaction survey shows very high satisfaction rate. So for example, is the location of medical facility convenient for you? How satisfactory are the conditions? The conditions, are you satisfied with the attitude towards you, etc. So there are very high percentages of the, for example, here is a good more in scores. So if we look at the at the other indicators, for example, have you received comprehensive information about 98% response positively? Do you think that it is convenient to receive HCV treatment and methadone substitution therapy at the same clinic? 98%. And 100% are recommending their family members or relatives, friends to be included in this program. So, so the provider attitude toward HCV treatment integrated services also show very high willingness of it to be included, but there were some concerns whether they could do this due to some technical restrictions. So it was very important to implement simplified algorithms of the pre-treatment diagnostics. So here you see the simplified one, which is much more simple than the full diagnostic measures which were done through the elimination program. Here is a simplified treatment monitoring algorithm. And actually there was a pilot study of the integration of HCV treatment with harm reduction services, and the goal and objectives of the study are shown here. So now I'll give you some results of this program. There were 3 sites in Tbilisi, Zugdidi, Batumi having on-site RNA testing to find arm 1 study support. And there was 1 private OST site also included using like Suboxone therapy. So these 4 sites were included as the first step of the integration and the decentralization of the HCV care. And it was very important to develop the simplified regulation, which is still very difficult to negotiate with the Ministry of Health. And because these centers were not like developed and constructed as a clinic, so they were like for different purposes. That's why they needed really simplified regulations, and we had a lot of like work done in this direction. And as a result, so overall referral rate of patients from harm reduction centers to specialized clinics were 24%. So in the algorithm, it was shown that the only patients with advanced like fibrosis are referred to the specialized clinics. Others are getting all service diagnostics and treatment on site. There were some main challenges which can be addressed, and one of them is really related with the regulatory issues mostly, and others with the technical issues which were really solvable. And the hepatitis C treatment outcomes among people with history of drug use shows that there is really no difference between the PWIDs. It's even higher, like sustained viral response rate than non-PWIDs. And as you see, there is a statistically significant difference between the rapid viral response, which is the indicator of the compliance with the treatment. So here we have even better results. So it shows that the concerns about non-efficient treatment through the decentralization are not supported. We have reverse data on that. And the conclusion is that the treatment outcomes among PWDs were similar to patients without the history of drug use, suggesting that adherence may be sufficiently similar to achieve responsive, reasonably comparable clinical outcomes. There was some study, just a couple minutes, and yeah, I'm done. So, of the barriers and facilitators to enrollment in HCV treatment program, and this main work was done by the harm reduction network in different sites in Georgia, and I want to show some results of this data. That there were comparison of those subjects who were linked to care and lost to follow-up. And as you see, not having enough information was statistically different in these groups. Age was really very important. In younger age, it was more difficult to link to care. There was a question about the trust, and there is no statistically significant difference between the groups, and whether the program is affordable or not. So to have a summary on all this data, there are several factors which can be addressed to make more efficient the inclusion. So there is more information. Even more important is that the program must be free, and from July this year we'll have totally free of charge diagnostic component for the elimination program. So this was already solved, so we are looking forward to have more patients enrolled in the program and increased number of clinics. There is another direction, as I mentioned, is that primary health care providers training and providing all tools for the treatment on site, and there is a plan to have 69 primary health care centers which will diagnose and treat HCV patients. And the final direction, and this is ongoing project, is the integration of HCV RNA testing on existing GeneXpert systems in Georgia, and this is supported by FIND. And this also will help us to integrate the on-site decentralization process of the HCV elimination program. So I think that the next step should be definitely decentralization of HIV diagnostics and treatment services in Georgia. I think the HCV program showed that this can really be very efficient. So why not? Thank you very much.